On this slide, we are comparing the two major types of neurogenic bladder. One is upper motor neuron bladder. So this is also called the spastic or hyper reflexic bladder, and lower motor neuron bladder. So this is also called the flaccid or areflexic bladder. So lower motor neuron bladder is called the flaccid or areflexic bladder. Upper motor neuron bladder is called the spastic or hyperreflexic bladder. So understanding this distinction, so this requires a clear knowledge of the normal maturation pathway. Normally, voluntary control begins in the prefrontal cortex, while the pontine maturation center coordinates simultaneous detrusor contraction with relaxation of the external urethral sphincter. So what happens is, normally voluntary control, normally voluntary control begins in the prefrontal cortex, while the pontine maturation center or PMC coordinates simultaneous detrusor contraction with relaxation of the external urethral sphincter. The sacral maturation center, located in spinal segments S2 to S4, receives descending input from the pontine maturation center and integrates parasympathetic outflow to the bladder. So this has been explained in another video. So here the sacral maturation center, so this is located in spinal segments S2 to S4. So this sacral maturation center, it receives descending input from the pontine maturation center, and this integrates parasympathetic outflow to the bladder. So voluntary control begins in the prefrontal cortex. Pontine maturation center, it coordinates simultaneous detrusor contraction with relaxation of the external urethral sphincter. So first discussing the upper motor neuron bladder, so which is shown on the left. So in the upper motor neuron bladder, the lesion is located above the sacral maturation center. Typically the suprasacral spinal cord lesions such as cervical or thoracic spinal cord injury, multiple sclerosis, cervical spondylitic myelopathy, or stroke after the spinal shock phase. So what happens in this upper motor neuron bladder? The lesion is located above the sacral maturation center, that is in the suprasacral spinal cord. Any lesions in the suprasacral spinal cord such as cervical or thoracic spinal cord injury, multiple sclerosis, cervical spondylitic myelopathy, or stroke after the spinal shock phase. So here the sacral reflex arc remains intact. Bladder contractions become reflexly mediated and uninhibited because descending inhibitory control from the brain is lost. Higher above the sacral maturation center, it is a descending inhibitory input will be there from the pontine maturation center, because when that is lost, the descending inhibitory control is lost. So the bladder will contract, it is reflexly mediated, and this is uninhibited. So because of this, what will happen? The detrusor will become overactive. Okay, so producing a small capacity hyperreflexic bladder. What is happening to the detrusor? It is becoming overactive. Okay, so it produces a small capacity hyperreflexic bladder. And a characteristic feature here is detrusor sphincter dyssynergia. What is the characteristic feature? It is detrusor sphincter dyssynergia, where the detrusor contracts but the external urethral sphincter fails to relax appropriately. So this lack of coordination causes high intravesical pressure. So what happens? There will be a high intravesical pressure. Detrusor sphincter dyssynergia causing high intravesical pressure. So this will result in incomplete bladder emptying and an increased risk of vesico-ureteric reflex, hydronephrosis, and renal damage. Okay. So clinically, patients will present with urinary urgency, frequency, nocturia, and urge incontinence, and residual urine is usually mild to moderately increased. So what are the clinical features? Urinary urgency, frequency, nocturia, and urge incontinence. residual urine is usually mild to moderately increased. On urodynamic studies, what is the hallmark finding? It is the detrusor overactivity. So when we do urodynamic studies, you can see the hyperactive or detrusor overactivity often accompanied by detrusor sphincter dyssynergia. So now moving to the lower motor neuron bladder. So this is illustrated on the right side. So here the lesion involves the S2 to S4 spinal cord segments. So here in the diagram you can see on the right side the lesion involving the S2 to S4 spinal cord segments, conus medullaris, cauda equina, pelvic nerves or peripheral autonomic nerves. So where is the lesion? S2 to S4 spinal cord segments, conus medullaris, cauda equina, pelvic nerves or peripheral autonomic nerves. Here the sacral reflex arc is destroyed. What is happening? Sacral reflex arc is destroyed. The detrusor will become areflexic and acontract. That is, it won't contract. Acontractile. Detrusor is becoming areflexic. In UMN, detrusor is hyperactive, but here detrusor is areflexic. So intravesical pressure here it is low or high? It will be low, okay? So but because the bladder cannot empty effectively, patients develop very large post-void residual urine volumes. So here you can see the very large residual urine. So clinically the dominant presentation is a chronic urinary retention with overflow incontinence rather than urgency. So here what is happening? It is a overflow incontinence. It is not urgent, okay? So the common causes include diabetic autonomic neuropathy, cauda equina syndrome, conus medullaris lesions, pelvic nerve injury following surgery and severe peripheral neuropathies. So what are the common causes? Diabetic autonomic neuropathy, cauda equina syndrome, conus medullaris lesions, pelvic nerve injury following surgery and severe peripheral neuropathy. So the characteristic urodynamic finding is detrusor areflexia or absent detrusor contraction. So in this table, it summarizes the differences, key differences between UMN and LMN bladder. In UMN bladder, the lesion is above S2 to S4. The sacral reflex arc is preserved. Detrusor activity is overactive. Bladder capacity is reduced. Intravesicular pressure is high. Residual urine is only mildly increased. And symptoms are dominated by frequency, urgency and urge incontinence. In contrast, in the LMN bladder, the lesion involves S2 to S4 or peripheral nerves. The sacral reflex is absent. The detrusor is acontractile. Bladder capacity is increased. Intravesical pressure is low. Residual urine is markedly elevated and patients present with urinary retention and overflow incontinence. So a simple way to remember this distinction is UMN lesion. The bladder contracts too much but empties poorly because the sphincter does not relax, resulting in small bladder urgency and high pressure voiding because of detrusor sphincter dyssynergia. So what happens in UMN lesion? The bladder contracts too much but empties poorly because the sphincter does not relax, resulting in small bladder urgency and high pressure voiding. Whereas in LMN lesion, the bladder does not contract at all, resulting in large bladder, urinary retention and overflow incontinence. So here you can see the urine which is retained because of detrusor areflexia. So this distinction is clinically important because high pressure UMN bladder, it carries a greater risk of upper urinary tract damage, whereas LMN bladders primarily predisposed to chronic retention, recent urinary tract infection and bladder over distension. So understanding these mechanisms, they guide appropriate evaluation with urodynamic studies, and this will help the management strategies such as anti-muscarinic therapy for overactive UMN bladder. For overactive UMN bladder, it is anti-muscarinic therapy, and or intermittent catheterization for acontractile LMN bladder. For acontractile LMN bladder, it is intermittent catheterization. Thank you.